Hi, everyone. Welcome. I'm Dr. Sydney Ortiz, and on behalf of Mount Sinai, I'm excited to introduce Just Talks, an equity and social justice lecture series brought to you by the Department of Psychiatry's Diversity, Equity, and Inclusion Steering Committee. Coordinated by the Community Engagement Subcommittee, this year's theme focuses on the relationship between psychiatry, mental health, and social determinants of health. And with that, I'm excited to introduce Dr. Lealah Pollock and her talk, HIV and Infant Feeding, Moving from Paternalism to Informed Free Choice with an Anti-Oppression and Reproductive Justice Lens. Dr. Lealah Pollock is a family doctor who specializes in primary and specialty care for women living with HIV throughout their lives, including during pregnancy and the postpartum period. She also has a special interest in sexual and reproductive health and care for transgender and gender nonconforming individuals. Dr. Pollock earned a master's degree in health and medical sciences at the University of California, Berkeley, and her medical degree from UCSF's Joint Medical Program with UC Berkeley. She completed a residency in family and community medicine at UCSF. Dr. Pollock's educational work focuses on training medical students and residents in care for underserved populations. She also teaches family planning to residents. As part of the National Clinician Consultation Center, she guides healthcare providers around the country on HIV prevention and treatment. Dr. Pollock enjoys traveling, camping, and cycling. She has ridden her bicycle, toting her tent down the California coast in Eastern Oregon and through France. Thank you for joining us. We're so excited to have you, Dr. Pollock. Dr. D'Amberville will now share how to collect your continuing education credit.
Hello, thank you everyone. I'm Dr. Naomi D'Amberville. Thank you again for joining us today on our Just Talks conversation. So continuing education credits for today's talks will be available to psychologists who registered for CE and for free to Mount Sinai affiliated physicians, nurses, psychologists, and social workers only. We'll be placing information on how to collect those CEs and CMEs in the chat throughout the duration of the talk. If you did not register via Eventbrite with your Sinai affiliated email and would like to be sure that you get CE credit for your attendance, please use the chat to DM myself or Dr. Timothy Stahl, your full name, your credentials, and your Mount Sinai email. Lastly, if you're joining as part of a group or a unit, please note each attendee's name and credentials so that each participant receives full credit. If you have any questions about the CE, CMEs, please place them in the chat and Dr. Timothy Stahl or myself will respond. As always, we encourage comments, reflections, and questions to Dr. Pollock in the chat box or in the Q&A box preferably. All questions will be answered at the end of the talk. So with that, Dr. Pollock.
Hi, thank you so much. Thank you for having me here. Thank you for continuing this very important series and work that you're doing. And I'm excited to be here to talk about HIV and infant feeding, really as sort of a case study in a change in medical practice and guidelines that is really a community-driven change. Like I said in the title, sort of moving from paternalism to informed free choice with an anti-oppression and reproductive justice lens. I'd like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of the lands that I'm sitting on now and that UCSF is sitting on, and would invite you and encourage you to look up the lands the unceded lands that you're sitting on, and think about how to interrogate your relationship to Indigenous people. Just a little bit about myself and sort of my positionality in relation to this topic. I am a clinician, a family physician with expertise in HIV that I bring from a family medicine perspective. I'm also a parent who has breastfed 3 children and is still breastfeeding my 3rd child. And I was actively encouraged by my medical providers to breastfeed my children. I have no lived experience of living with HIV, and I just want to acknowledge that my experience is not representative of the racial groups most disproportionately impacted by HIV. I am a white physician. Sorry for the typo on the slide. And also my perspective is informed by my experiences in patient care, scholarship, advocacy efforts relating to this topic, and also my personal experience as a patient and a parent with privilege. And so that is what I bring to this topic. My learning objectives today, I'm hoping to examine the evolution of infant feeding recommendations for birthing people with HIV in the United States, describe the current infant feeding recommendations through an anti-oppression lens and a reproductive justice framework, and think about ways that members of the healthcare team outside of traditional HIV care spaces, including mental health providers, can support people with HIV who choose to breast or chest feed. Just a little note about language. I myself would encourage anyone who participates to really try to use people first language for people with HIV. So person living with HIV, not HIV infected person. Avoid stigmatizing, blaming language. So I use perinatal transmission or vertical transmission instead of mother to child transmission. And also thinking about gender inclusive language, remembering that not everyone who gives birth or feeds a baby identifies as a woman. And I'll use the terms breast and chest feeding to refer to the process feeding a baby your own human milk, recognizing that other people may use other terms for themselves. So first, I'm going to go over a little bit of background on what is reproductive justice, and then a little bit of the history with HIV. So hopefully all of you know about reproductive justice. I don't claim to be an expert in RJ, but I do want to take a moment to pause to define RJ and to really think about using this framework as you listen to and reflect on the rest of the talk. Sister Song defines reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. This movement arose in 1994 when there was a group called Women of African Descent for Reproductive Justice who met in Chicago right before the International Conference on Population and Development in Cairo, Egypt. And it rose out of a recognition that reproductive health for Black women and women of color is not as simple as the framework that was being presented by a predominantly white group of feminist women as really focused on choice and the choice for abortion. So RJ is really focused on understanding reproductive liberty beyond the theoretical right to choose abortion, and more so examining the structures and oppressive societal forces that impact all aspects of reproduction and that disproportionately impact Black and Brown people. And so again, I'm going to go over a little bit more and then think about sort of using this framework as we go through the rest of the topic. So this is a quote from this book, Reproductive Justice: An Introduction by Ross and Solinger. And they ask, which persons, which women do politicians and ordinary people define as fit to be mothers? Sort of thinking about whose mothering and parenting rights are affirmed and whose are harmed and diminished. And thinking historically through the history of the United States, starting with European settlers, we know that European settlers used genocide and enslavement to colonize the United States and entrench ideas about sexuality, reproduction, and value that really elevated whites and denigrated others. Historically and currently, poor women, disabled women, women of color, immigrant women, and women living with chronic disease have been deemed unfit to parent. And starting in the eugenics movement, really this was placed in the medical literature as being a scientific fact. And really, these assumptions and biases live on in medicine and science today. And so when you think about laws, regulations, assumptions, medical practices that affect reproduction, it's really important to think about how does this history and this legacy really impact who we think of today as being fit people to be mothers, and whose reproduction we value and whose reproduction we degrade. And today there are laws and policies that promote childbearing among some populations and penalize it among others. Really, motherhood remains a race and class privilege in the United States. And throughout this history, upholding the nobility of white middle-class maternity has always depended on the definition of others as unfit, degraded, and illegitimate. This racialization of who is a fit parent really intersects with HIV in a number of different ways. One is people living with HIV being people who are living with a chronic disease and living with a chronic disease that can be transmitted through childbirth, through breast and chest feeding, but also very relevant to HIV because there are huge, as with many other things in medicine, there are huge racial disparities in HIV diagnoses. So you can see here in this chart, this is the latest data from 2022, which unfortunately may be the last year for a while that we have good data on HIV diagnoses and transmission. So you can see on the left, HIV diagnoses, so 24% of new HIV diagnoses among cisgender women in the United States were among white women, 50% among Black or African American women, 20% among Hispanic or Latino women. And then you can see on the right the proportions of each race in the US female population. So you can see that Black and African American women made up 13% of the population and 50% of new HIV diagnoses. And we know that this is really due to the impacts of structural racism. So impacts of structural racism, such as incarceration, poverty, low educational attainment, and lack of access to healthcare, really contribute to the increased risk of HIV acquisition among Black women, despite many studies that show that Black women practice the same sexual behavior in terms of condom use and number of partners as women of other races. There's also been some literature about how racial segregation, along with mass incarceration of Black men, may limit the number of available partners to Black women and thus may contribute to the formation of more insular sexual networks with overlapping concurrent partners. And as a result, many Black women in these communities, and we know that HIV is also very geographically focused, with the highest rates right now of new diagnoses in the Southeast part of the United States. And so people in these communities can face greater exposure to HIV acquisition with each sexual encounter and may potentially underestimate this consequence. And so this is just a little bit of background about how structural racism impacts both reproduction and the sort of science and medicine of reproduction, and also impacts rates of HIV acquisition. So now I want to give you a very brief overview of the history of reproductive coercion and HIV in the United States. So these concepts of reproductive justice and structural racism intersect with HIV stigma to lead to many instances of reproductive injustice for people with HIV. In order to understand the current context of infant feeding, I think it's helpful to reflect on the history of reproductive counseling, which was really coercion, in the history of the HIV epidemic in the United States. So in the setting of many unknowns, CDC published its first MMWR about perinatal HIV in 1985, including language that, quote, infected women should be advised to consider delaying pregnancy until more is known about perinatal transmission of the virus. While not included in the MMWR, one of the CDC officials at the meeting when it was written said, quote, women with HIV and their sexual partners would have to suppress often strong desires to bear children. In 1987, the San Francisco Department of Public Health, where we know, in San Francisco and in New York, were two of the sort of initial hubs of the HIV epidemic. And the San Francisco Department of Public Health wrote that, quote, whenever possible, women infected with HIV should be confidentially identified and educated about the risks of perinatal transmission. Infected women should be advised to postpone pregnancy. Pregnant women should be counseled to postpone subsequent pregnancies. And in 1987, ACOG came right out and said what was sort of the subtext of all of these other statements, that, quote, HIV-infected women should be strongly encouraged not to become pregnant and should be provided with appropriate family planning assistance. So at the same time that this language was coming out, there was also a lot of conversation about how to approach genetic counseling for women with genetically inherited disorders. And at the same time that these statements were coming out saying women with HIV should not have babies, public health officials and providers were really having a conversation about supporting a non-directive approach to genetic counseling in women with severe genetic conditions. And so I think it's helpful to think about sort of why was HIV really treated differently from other potentially heritable conditions. So we know that this was all happening also in the context of the war on drugs. And so racism, HIV stigma, classism, and the war on drugs, which was also steeped in racism and classism, and other oppressive forces really conspired to blame people living with HIV, and sort of still feeds the narrative of babies as victims of their parents' misdeeds, both in medicine and public health and in the social imagination. In 1989, CBS broadcast a made-for-TV movie called The Littlest Victims about babies with perinatally acquired HIV and really cast them as being victims of their parents, really needing to be saved by these white medical providers, as you can see in this picture. So I want to also recognize that not everyone was feeding into this approach of trying to control and demonize the reproductive choices of people living with HIV. There were brave people such as Dr. Janet Mitchell, who at the time was chair of OBGYN at Harlem Hospital and challenged the CDC in 1985 when they were writing their guidance. She really challenged them to use a non-coercive approach to HIV and reproductive health, similar to genetic counseling. When she spoke out about the history of reproductive coercion faced by Black women in public hospitals and how this was being repeated in this context of HIV, CDC officials responded, "Don't you want to stop the spread of AIDS to infant?" And sort of cast her as wanting to harm infants instead of somebody who was really standing up for the rights and the voices of Black women and their families. And I just want to say, you know, this is sort of feels like an appalling history in retrospect, but we are having analogous conversations right now about infant feeding. And really, you know, I think if you look and think, you can see these conversations happening in the context of the reproduction of many different populations in the United States. And so really thinking about it's important to create space for dissent and invite accountability. I also want to recognize that there is a long and very important history of HIV activism in New York and San Francisco, in the United States, and globally since the beginning of the epidemic. So I am here sort of wearing the mantle of an expert as a medical provider, but really those living with HIV have been lighting the path of justice from the very beginning. And most of us with power have not consistently listened and still struggle to listen and to give weight to those voices. This is a picture of women living with HIV and HIV activists at the International AIDS Conference in 2018, demanding that they have choice around antiretrovirals. In the context of an antiretroviral sort of being discouraged from being provided to cisgender women because of a theoretical impact on infant development. Sorry, on fetal development. So I really want to honor those who have been advocating for a long time that we use a reproductive justice approach to infant feeding, and whose advocacy and work I have had the great honor to be able to follow and learn from. And I want to really recognize the Well Project and all the activists, community leaders, people living with HIV, and lactation consultants who've been shining a light on the path towards reproductive justice. And this is just a picture from a listening session that was hosted by the Well Project in 2022, and also a really important book that was written by a lactation consultant. So to get a little bit into sort of the science and the guidelines, I was going to talk a little bit about how the guidelines have evolved and what we currently know about the risk of lactational transmission of HIV to provide some additional context. So looking at World Health Organization guidance, for the first 2 decades, they recommended replacement feeding when, quote, safe and feasible. So in countries that had access to clean water supplies, formula was recommended. In places that did not, breast or chest feeding was recommended. And this sort of split guidance was because it was recognized that infants who did not breastfeed suffered high mortality from diarrhea and other infectious diseases, and that breastfeeding actually conferred a higher HIV-free survival to infants. In 2010, globally, there was a big shift to more support of 12 months for breastfeeding. And this was also in the context of increased ART access for pregnant women with HIV. And then as data has mounted about the lower risk of transmission with the rollout of antiretroviral therapy, support of breast or chest feeding has increased. In 2016, in the WHO guidance, the breastfeeding recommendation was extended to at least 12 months and up to 24 months, along with support of ART adherence for mothers. But that recommendation is really different from the guidance that has been present in the United States and in other high-income countries. So until 2015, in both the CDC and the DHHS perinatal guidelines, there was a blanket prohibition on breast or chest feeding for women living with HIV. So really the recommendation said, don't breastfeed. In 2015, there was sort of this sentence added. There was recognition that people living with HIV face some pressures around infant feeding, that people, especially people who were either immigrants from low and middle income countries, or were sort of moving back and forth between countries, or had family or friends in other countries, were sort of asking the question of, why is my milk valued differently here than it is back home in Kenya? And so there was this sentence added that individuals may face environmental, social, familial, and personal pressures to consider breastfeeding, despite the risk of HIV transmission via breast milk. In 2018, there was a more significant change. We added a separate section on breast or chest feeding that still said it's not recommended, but if you counsel somebody and they really decide that despite your advice, they're gonna breastfeed, let's support them. So it was still really directive counseling, but with some room to support somebody if they didn't do what you were telling them to do. And then in 2023, there was really a significant change where the DHHS really sort of shifted towards a context of shared decision making. And that said, really, people with HIV should receive evidence-based counseling to support shared decision-making about infant feeding. That basically either replacement feeding with formula, or in somebody who has a consistently suppressed viral load, that breastfeeding is an option, and that people should be supported in their decision-making. These guidelines also explicitly state that referral to Child Protective Services or other family welfare agencies is not an appropriate response to people who ask about breastfeeding or who choose to breastfeed. There are many very heartbreaking stories of providers threatening to call or calling CPS, and also of providers refusing to provide care to people with HIV who choose to breastfeed or to their infants, often really in an attempt to intimidate and coerce someone into not considering breastfeeding. We know that both calling CPS and refusing to provide care are inappropriate and harmful responses to someone making a decision that you don't agree with. For women and birthing people with HIV and their families, infant feeding decisions are complex and nuanced and take place against a backdrop of structural racism, gender inequity, and economic injustice. Involving CPS or refusing to provide care shuts down conversation, furthers HIV stigma, pushes people out of care, and fits into a pattern of biased policing and application of policies that lead to the most marginalized, particularly Black and Indigenous communities, being unjustly surveilled and punished for reproductive-related health decisions. And really, this change has been driven by community members and advocates. So the development of these 2023 guidelines involved input from community members and people with lived experience, recognition that the risk of HIV transmission through breast or chest feeding is very low in the context of ART and viral suppression, and that there is a strong community desire for bodily autonomy, reproductive justice, and shared decision-making. Also, recognition that restricting breast or chest feeding might increase the inequities that already exist for many birthing people with HIV. And then consideration of the ethical justice and autonomy arguments that given the benefits of breast or chest feeding and the low risk of HIV transmission, breast or chest feeding with HIV should be an equal poised decision for people on ARVs with an undetectable viral load. And that really these decisions should not be driven by medical providers, but should be driven by people living with HIV. So let's talk a little bit about sort of what we know about the risk of lactational transmission. One of the greatest landmarks in HIV recently has been the recognition that when somebody is on medications with a suppressed viral load, the risk of sexual transmission is effectively eliminated. And this is important not just for implications on prevention, but for the lives and the sexual and mental well-being of people living with HIV, to really take away some of the stigma and fear, and to say, we know from science that if your viral load is suppressed, you actually can't pass HIV to a sexual partner. And so this is the U equals U campaign. So what do we know about U equals U in transmissions? Like I said, we know that with sexual transmissions, there's effectively no risk of transmission. With perinatal transmissions, there's a large body of data that says that if a pregnant person is on ART before they get pregnant, continue it throughout pregnancy and have a suppressed viral load during the third trimester and at delivery, that there have been no transmissions of HIV in that context. In terms of lactational transmission, we know that the risk is very low, but that it may not be zero. And we really don't have enough information yet to know if there's a scenario where undetectable will equal untransmittable. So some of the best data about the risk of lactational transmission is from the PROMISE trial. So this is a trial where women who were receiving treatment, people were randomized to either continue their ART postpartum, or their infants were provided with prophylaxis throughout the breastfeeding period. And so in the context where women were receiving ART throughout breastfeeding, there was an overall risk of lactational transmission of about 0.6% at 12 months. So out of 1,000 women in the study, for every 1,000 women in the study, there were 6 HIV transmissions. So this is a very low risk, but it's not a zero risk. And it leads to the question of whether any of these transmissions occurred in the context of virologic suppression. So we do know that there were 2 lactational transmissions to infants who had recently achieved virologic suppression. So there were 2 cases. One was in somebody who, as you can see, was not undetectable at delivery, still had some viremia while she began breastfeeding, and then the baby tested positive for HIV later in her breastfeeding course. And another was somebody, again, who was detectable at delivery, achieved an undetectable viral load sort of right at the time that the baby was diagnosed with HIV, and then went off of her ARVs again. So we really don't know sort of would this have happened if they had achieved suppression earlier. This is a study where women were only offered ART in the 3rd trimester at delivery. So very different from the context that we're talking about for people in the United States who are desiring to breast or chest feed. There have been some other case reports of lactational transmission when the breast or chest feeding parents seem to have an undetectable plasma viral load. But again, these were all ART starts in the 3rd trimester or closer to delivery. So again, we don't know what the risk is really if virologic suppression is achieved before or early in pregnancy and throughout and maintained throughout pregnancy and lactation. But we can't tell our patients that there's zero risk of HIV transmission if they breastfeed their babies. And so that is a very important part of the conversation and the counseling that we do. But I think it's also important to ask, is HIV transmission the only consideration when we think about infant feeding decisions. So when it comes to that residual, very low, much less than 1% risk of HIV transmission, and also knowing that if an infant does acquire HIV, it is a treatable chronic condition, how do we balance that residual risk with the known benefits of breastfeeding? And really, I think the big question is, who gets to decide where that balance lies? So beyond the risk of HIV transmission to their baby, people with HIV may be thinking about the stigma and lack of privacy they face when they don't breast or chest feed. They may be thinking about the health benefits of breast or chest feeding, and they may be thinking about the goal of having the same choices and health outcomes of people without HIV. We have a patient in our clinic who we've been seeing recently who was diagnosed with HIV pretty much at the same time that she found out she was pregnant. And really her first question was, does this mean that I can't breastfeed my baby? This really just sort of shook her whole conception of what it meant to be pregnant, what it meant to be a parent, what it meant to have an infant. And so these have been really important conversations that we've been having about, what does it mean to choose to breastfeed? What might it mean to choose to breastfeed? What might it mean to choose not to breastfeed? And they're important and they are challenging conversations to have. And just to also sort of point to the continued reality of HIV stigma. This person also, when they went to get their blood drawn, local lab, the phlebotomist drawing their blood told them that their baby was going to have HIV, which is one, not true at all, and two, not in any way the role of a phlebotomist to even weigh in on. So HIV stigma is still very, very real and alive. So if we want to have even the smallest chance of doing right by people living with HIV and their families, we need to start by listening. So I'd like to spend a few minutes sharing some quotes collected through qualitative and mixed methods research from people living with HIV, how they think about and talk about feeding their babies and the choices they had or more often didn't have. All of this research was conducted with cisgender women, so I will use gendered language used by the participants in describing the results. I want to start with this quote from Claire Gasamagera, who's an HIV advocate, who said, as a woman born with HIV in Africa, people have told me what to do with my body my whole life. When I moved to the US, I was confused when they told me I couldn't breastfeed. Another example of someone else deciding what was best for me. I wish women living with HIV in the US could be empowered to make informed decisions when it comes to breastfeeding. I urge providers to trust women living with HIV and provide them with information and services to help support their choices. For some people, breastfeeding is part of the cultural expectation of motherhood, and not having this option can come at a steep emotional cost. This person said, I just accept it, but in my heart, it pains me because as a woman, you have to breastfeed your baby. Because breastfeeding is such an expectation of new motherhood, people with HIV talk about having to explain themselves over and over again and make up excuses for not breastfeeding. This first woman said, it was difficult. I mean, I had so much company coming over here when I first had the baby, and they all asked me why I wasn't breastfeeding, every single person. There's a particular importance of breastfeeding for many migrant women from countries in sub-Saharan Africa, where not breastfeeding arouses suspicion and may actually out a mother's HIV positive status. As this woman said, the challenges from not breastfeeding is the people around me, right? It's so sad because most people, like most Africans, they know that the moms who do not breastfeed are moms who have HIV. They know about that. So sometimes if they come to your apartment, they'll be watching to see if you're going to give the baby milk. There are also very well documented health benefits to breastfeeding for both parent and baby. And as this person said, I want to breastfeed because from what I read in all the books, breast milk was the best. So I just wanted to give that to my baby. Prohibiting breast or chest feeding may exacerbate health inequities. Those with limited access to social and health resources are the most impacted by HIV, primarily due to the effects of structural racism, and these same populations experience a greater burden of health conditions that may be attenuated by breast or chest feeding. We also know that formula is expensive. And while breast or chest feeding can be hard, it can also be really convenient in the middle of the night. As this woman said, it's a lot of work all the time. Keep sterilizing, washing, boiling water. It's not easy. During the nights, I'll get up stressed because I have to get up and boil water all those times if he cries or if he needs to drink. WIC actually only covers people under a certain income limit, and it only covers certain brands and types of formula, not the fancy organic kinds that have been popular for a long time and that are being pushed by RFK Jr. and the MAHA movement right now. Also, the idea that formula is safe and available in the United States really came into question a few years ago when babies were getting sick and even dying from contaminated formula. And formula shortages were also leading to articles about how to reinitiate breastfeeding. If you'd stopped months before, people were really scared about the lack of access to formula. Also, we've seen in Flint, Michigan, in parts of Appalachia, and in other parts of the United States, clean, safe tap water is not always a given in the United States. And actually, there's a huge part of the population that rely on well water and other unregulated sources of water. So what we've heard from people with HIV is that even if somebody ultimately chooses to feed their baby formula, the directive counseling they receive feels degrading and harmful and strips them of agency. So one woman said, I was always told since my first pregnancy that I could only formula feed. When I continued to inquire about it, my nurse said to me, do you want to give your child HIV? Then you can't breastfeed. I was so hurt by this response, I haven't inquired since, even after multiple children. When given information and the choice to breast or chest feed, many people will still choose formula, or maybe some may have access to banked human donor milk, but the fact that they had a choice is still important. This woman said, I was sad because I wanted to breastfeed again, but then I thought, well, it's my choice, and I don't want to give any risk at all to my baby. This is a study that was done in the UK and also in one of the links I provide at the end. There's a link to the website from the study where they actually have a number of videos of actors reading quotes from this study. It's all very powerful. So these are some reasons that women living with HIV in the UK gave about how, when given a choice, they ultimately decided to feed their babies. So you can see here in the motivations to breastfeed column, people talked about the health benefits for parent and baby. People talked about bonding. People talked about cultural expectations, and then people also talked about how not breastfeeding could disclose their HIV status, as we talked about earlier. And then people also talked about their motivations to formula feed, primarily the motivation to avoid HIV transmission, but also for some people, the convenience of formula feeding, the ability to share feeding duties for somebody else to get up and give the baby a bottle in the middle of the night, and also the lack of support for breastfeeding. So people who said that they didn't have any providers who would support them if that was their choice. So coming back a little bit to why feeding choice is a reproductive health or justice issue, the most obvious kind of ethical argument to support shared decision-making in infant feeding is bodily autonomy. As we've talked about, women have a right to make informed decisions about their own body and family. And you know, this is not a universally accepted concept, especially in today's political climate, where there are a lot of people arguing for sort of quote unquote parent choice in a way that actually only privileges the choices of white and middle upper class women, and then also people across the United States really stripping women and other birthing people of their reproductive rights. And, you know, I think also there are very well-meaning arguments that somebody needs to represent the voice of the baby, or that women don't have autonomy to make decisions that could potentially lead to harm to their infants. And I think, especially as a family physician who's trained to take care of the whole family, including parents and their children together, I think this really creates a false dichotomy between a mother's health and well-being and her child's health and well-being. Most parents are really making the best decision they can for their family within the constraints of the given circumstances. And we need to help support them to both clarify and improve their circumstances, to make sure that they have education and knowledge to empower them to make decisions. And to not assume that a desire to breastfeed or a desire even to have babies is selfish or that it disregards the health of their infant. And then there's also an argument, which I alluded to earlier, about the justice argument, and that compelling somebody to formula feed could potentially exacerbate health inequities. So this is Gross et al. In a 2019 article in the Journal of Law, Medicine, and Ethics make, I think, a compelling justice argument where they state, quote, current recommendations against breastfeeding likely further disadvantage already disadvantaged women and infants, largely due to existing socioeconomic and racial disparities. Unfortunately, minority women suffer disproportionately from diseases breastfeeding may prevent, such as obesity, hypertension, heart disease, stroke, depression, and female cancers. Furthermore, there's increasing but conflicting evidence that potentially ARV use in pregnancy could increase the risk of prematurity and low birth weight. That seems to be more true in low and middle income countries than in the United States. But still, we know that small and premature babies are the ones who can benefit most from breast milk. So when we think about sort of the 4 principles of healthcare ethics, autonomy, non-maleficence, justice, and beneficence, we can see that really the autonomy and justice, the respect a person's freedom to choose what's right for them and treat and provide care fairly to all patients, are really principles of healthcare ethics that are really applicable to this conversation about infant feeding for people living with HIV. And as I also have said before, and as I think we're all very, very aware, reproductive autonomy is truly under assault in this country. And I really invite all of us, and this is something that I really try to reflect on a lot, to explore ways that we have denied our patients autonomy and prioritize not just honoring our patients' autonomy, but also where we can give people choices to begin with. And when we center informed free choice in our one-on-one interactions with patients, but also in our clinic protocols, hospital policies, national guidelines, in our institutions, and in our research. And just to, again, really highlight sort of the ways that HIV stigma and increased exposure to HIV intersect with the lack of bodily autonomy. This is a map from 2022 of the rates of people living with HIV per 100,000 when sorted by female sex. And you can see that really HIV is an epidemic that is concentrated in the Southeast. You can see also, higher rates in and around New York City and the Northeast, where you guys are as well. And then when you compare that with a map of where abortion bans have been enacted as of December 20th, 2024, you can see that there's really a lot of overlap in places where people have more exposure to HIV and places where they have more restrictions on their bodily autonomy. So thinking about sort of how can we support people with HIV to make informed, supported, uncoerced infant feeding decisions? One question that we can start with is just asking somebody, have you thought about how you would like to feed your baby? And then also we know that when a parent living with HIV chooses to breast or chest feed, support is fundamental. And so this is again an infographic from the Well Project and a quote from a breastfeeding mother with HIV who said, all I wanted to do was feed my baby. I wasn't seeking approval, I just needed support. And so this really involves a team approach where we think about support from peers, from providers, from lactation experts, from family members, and from mental health professionals. And that piece of involving mental health professionals is really important because we need perinatal mental health professionals who are aware of some of the challenges that women living with HIV may be facing that are unique. And also, we hear from women living with HIV about the impact on their mental health of not breastfeeding. That, we know that there are some studies that show that breastfeeding can decrease the risk of postpartum depression. And so thinking about when you see somebody with postpartum depression, how might their infant feeding modality or their ability to make decisions or not make decisions kind of weigh into what's going on with them and their mental health in that moment. And then also thinking about, for people who do choose to breast or chest feed, there can be a lot of anxiety in that decision, even as they know or feel like, this is the right decision for me and my family and my baby. They can still be really having a lot of anxiety and thoughts about, okay, but what if, but what if, but what if? And so really the importance of mental health professionals in helping to support pregnant and postpartum women and other birthing people living with HIV. And so as I've talked about and shared, the history of reproductive and sexual health for people living with HIV has been steeped in coercion, lack of choice, paternalism, and criminalization. The needle has slowly been moving from criminalization, coercion, lack of choice, to more harm reduction, to shared decision making. And really, I think we're getting to a place where we're really thinking about how can this be a framework of informed free choice. The dominant public health goal in HIV has been getting to zero, and that's still an important goal. And eliminating HIV transmission is critically important. But I invite all of us to think about how can we not just get to zero, but how can we get to equity? How can we get to justice? And how can we get to informed free choice? I'd like to end with some reflection questions just for people to sort of take away. So thinking about within other realms of reproductive or sexual health, how have you used evidence, our own priorities, and or our own fear in a way that reinforces power over our patients and the communities we serve? How can we bring personal and institutional humility to what we think is correct? How would an anti-oppression and reproductive justice lens change your perspective on patients making choices that differ from your opinions? And what clinical practices have changed because of evidence and or advocacy? And how do we engage in a collective process of repair for those harmed by outdated practices and guidelines? I'd also just like to share a resource. I work at the National Clinician Consultation Center. I'm the clinical director of the Perinatal HIV Hotline. Perinatal HIV Hotline is a 24/7 hotline that takes calls from providers across the country related to pregnancy, breastfeeding, and HIV. And then as you can see here, we have a number of other different lines. We have an HIV/AIDS warm line, a hepatitis C line, a PrEP line, a PEP line, and a substance use warm line. And we'll soon be launching a reproductive health hotline as well. And I'd like to thank you. Sydney is going to put some resources in the chat that I wanted to share with everyone. Thank you. She already did. I think, unfortunately, the links didn't work. Don't seem to be there for the additional resources, but maybe we can try to sort that out. And I would welcome any questions or comments. Thank you.
Thank you, Lealah, so much. I'm going to work on getting those links set up in the second part of the chat that I shared with folks, but we have a number of questions from people. And if folks continue to have questions, please place them in the Q&A or in the chat boxes. Our first question is, how can folks like health educators, psychologists, social workers, et cetera, support folks with HIV in their decision-making about how they'd like to care for their child? I want to acknowledge that we may not have the same knowledge as physicians, but still want to support our patients.
Yeah, that's a great question. And so I think that, one is just sort of coming from a place of curiosity, which I think that social workers and psychologists, I have learned a lot from my colleagues and how to sort of ask questions and approach things with curiosity of What do these decisions mean for the patient? What have they heard or been told so far? And then seeking out information for yourself from resources such as the perinatal HIV hotline. So we actually, if you have questions about, what is sort of the evidence behind this, what should the counseling be, we are available. And then I'd also really encourage you, to reach out to that patient's primary care provider or HIV provider, to have a conversation and to learn more. I think what, I am sure that many of you have seen, what I have certainly seen in my practice is that a lot of times patients bring things up with their social worker or with their therapist long before they will bring them up with me. And so sometimes the way that I learn about some of the concerns or questions that my patients have is through our teamwork with our social work team, and really asking permission for can we talk to each other and can we support you together? And so it's a really important question, a really critical role.
Yeah, I think it's a great point about just collaborating as a team to serve the folks that we see in the places where we work. We had a second question. So can you place your history of HIV and reproductive coercion in the 1980s in the context of availability of antiretroviral therapy to prevent transmission? Is it possible that public health experts were hoping to prevent the spread of HIV to infants rather than controlling women? I believe it was not until 1994 that antiretroviral treatment was proven to reduce vertical transmission.
Yeah, it's a great question. And you are absolutely right that, in the 80s and into the 90s, there was very little information. So I think, thinking similarly to what we have just gone through in the last 5 years with the COVID pandemic, that when HIV first started, people didn't know a lot about how it was transmitted, how to prevent it. AZT wasn't available yet. We certainly didn't have combination antiretroviral therapy, and we didn't have the data about how to prevent perinatal transmission of HIV. And so I think that you are absolutely right. Public health experts were really, I think, coming from a place of caring, of wanting to prevent HIV transmission to babies. But an unintended consequence of that was reproductive coercion and control. And so when we are faced with these sorts of unknowns, I think what I'm sort of offering or inviting is think about, one, how can you involve the community that's impacted by HIV? There was a lot of very important activism with ACT UP, with other activist groups, really asking for, we need research, we need access to treatment. A lot of that activism was from gay men and people advocating for gay men, and it was very important. But the voices of women living with HIV were very much left out of that conversation early on. And it's not that there weren't people out there advocating and asking questions, but they were not the dominant voice being heard and being sort of included in advocacy and activist movements. And the other thing is just thinking about, just sort of reflecting on how might the conversation have been different if the population most impacted with HIV in the 80s were middle and upper class white women instead of predominantly Black and brown women, who were also often substance involved, often living in poverty, already subjected to reproductive coercion and devaluation of their bodies and lives and families. And so I think just sort of thinking about that sort of hypothetical, and I think there have been, we have learned when Zika happened, the first messages were a colleague of mine who was in an early meeting said that a public health official said, well, women are just going to have to cross their legs. And so the initial sort of knee-jerk reaction when Zika happened was to say, well, there's a risk to babies, just tell people not to have sex. And I think because of the work that reproductive justice had done, that the reproductive justice movement leaders had done already, there were actually people in the room who were able to say, you know what, like, let's talk about how to how to give information, how to support people in making choices. To just tell people don't have sex, don't have babies. One, it's like, it's not realistic. And two, it doesn't honor people's ability to be able to take in information and make informed choices about how to build their families in the face of a lot of unknowns and a lot of always health risks potentially to our babies.
I think related to that question and the supports that can be present for folks parenting with HIV is a question about, in an ideal world, this person is curious, separate from medical care, and you spoke about this a bit. What supports do you recommend for parents with HIV?
Yeah, I really recommend so a couple of things. So for people who choose to breast or chest feed, I think having an informed and supportive lactation consultant is really important. Having mental health support is really important, and having peer support is incredibly important. So I'm in San Francisco, you guys are in New York. We are in settings where we are fortunate to have um, sort of large enough populations to have peer support groups. And so finding out where those are, helping people connect. And then also there's a lot of virtual support groups as well. So the Well Project is a national organization that supports women living with HIV. And one of their big projects has been around breastfeeding equity. And they have a closed private Facebook group for women living with HIV who are thinking about breastfeeding and who are breastfeeding. And so through that group, they provide a lot of support to each other. And it is moderated by two women living with HIV who have breastfed their own children. And then, and there are some other groups in different places here in the Bay Area. We have World, which does like outings for people living with HIV. We have an organization that has tried to do more like groups for younger parents living with HIV. So there is a lot of support out there. And I can't stress strongly enough just how powerful peer support is, especially, HIV, again, it's so stigmatized. It can just feel a new diagnosis can feel so lonely from what I've seen in my patients and people I've talked to.
Thank you. Dr. Pollock, in general, how can mental health providers engage patients of all genders in conversations around breastfeeding in a way that is sensitive, culturally informed, trauma informed, sort of enhance breastfeeding equity, but also like really address the ways in which these might be stigmatized or again, just the uneducated, including ourselves as providers who might not know all of this information?
Yeah, it's a great question. And I think, a lot of it, I imagine actually just starts with using the tools that you're already equipped with and the skills that you have to really explore, what's going on for somebody, thinking about their own history and their history of trauma and how that impacts even their ability to engage in medical care. And then also, I think a really important role that mental health providers play is in, I as a doctor, I can like give the information, I can sort of try to help somebody understand what does 0.6% mean. But really understanding like what is the meaning of these experiences and options for somebody is something that I think mental health providers are much more equipped to do, and hopefully have a little more space to explore of sort of what does parenting mean to you? What does being pregnant mean to you? What does it mean to you to be having a baby as a Black woman living with HIV? Or what does it mean to you to be having a baby as somebody who yourself was acquired HIV through vertical transmission and have been living with HIV since you were born. That is a population that right now are in their sort of peak reproductive years, and are dealing with a lot of the sort of repercussions of lifelong stigma and living with a chronic disease. And I guess that's the other thing is I'm sure that you work all the time with people living with other chronic diseases. And so thinking about, how do you talk to somebody with diabetes who is pregnant or thinking about pregnancy? And HIV has long been sort of siloed as this other scary sort of specialized disease. But more and more, it really is a chronic disease that's managed with medications the same as other chronic diseases. And so, so really recognizing the expertise that you already have is really important.
Thank you so much, Dr. Pollock. We're going to end. And so thank you so much for your emphasis on, providing the historical context and the guidelines on treating and supporting individuals with HIV in their breast and chest feeding choices, and particularly noting how we as a society has sort of really shifted to reproductive justice and an informed choice lens for a group of people who have been really stigmatized and lacking support. So I'm glad to hear all the support and to hear how there are still gaps in this, in this work that you as physicians and we as mental health providers can really work on looking at more deeply. So thank you, Dr. Pollock, for joining us. We hope you all enjoyed today's talk and found it relevant to your practices and the communities that you serve. Again, a recording of today's and all the other talks will be posted on the Just Talks YouTube page. So feel free to join us next month. Thank you all.
Thank you. Thank you, Dr. Pollock.
Thank you so much for the invitation and the fantastic questions. Appreciate it.
Thank you.
Bye, everyone.